Here are my disclosures. I'm going to talk to you about the IPED study, which was funded by a British Heart Foundation and Chest Heart Stroke Scotland grants, which included funding of the AliveCore device. And AliveCore themselves had no involvement in the study I'm about to present. So this is Mrs. M. Mrs. M was out for lunch with a friend in Edinburgh when she suddenly felt palpitation and dizziness and felt extremely unwell. By the time she arrived in our emergency department, she felt back to normal and she had a normal ECG. This had happened on a number of occasions previously, to the extent that Mrs. M had become worried about going out even to walk her dog, as she had become more aware of the lack of seating outside of her house as she did start to feel unwell again. So palpitations is very common. We see an awful lot of patients per year in the emergency department, and it's also very common to present to the general practice. And the problem is that the only way to make a diagnosis is to record an ECG at the time of symptoms to get an ECG symptom correlation, and that can be very difficult. And we have many patients who present to us. The symptoms have settled by the time they've come to the emergency department. Their 12-lead ECG is normal, and we have very little to offer them. We advise normally to return if they should get symptoms, to attend the GP for an ECG or to phone an ambulance to try and get an ECG while they're having symptoms. And the reason is that the standard care is generally a Holter, a monitor, and the diagnostic yield is very poor for picking up palpitations during the period of monitoring. So we came across the cardiomobile technology several years ago, and what it is, for those of you who haven't seen it, is a device where there are two electrodes, and the patient can put two fingers on each electrode. And if they're out and about and develop symptoms, whether in the supermarket, for example, they can just sit down, grab the device from their handbag or wallet, and they can record an ECG for 30 seconds. And the ECG is connected up to their smartphone, and the ECG is on their smartphone, so they can either take that to their general practitioner, to a hospital clinic, or they can email it to their general practitioner. And the device is also able to interpret it, and it gives you here, hopefully see that's a normal ECG for me, which is good. But it also gives you a diagnosis of atrial fibrillation, a tachycardia, or a bradycardia. So we thought this would be hugely helpful in our palpitation population, and we set out designing and conducting the IPED study, which was published last year in the Lancet eClinical Medicine. So this is a multi-center, open label, randomized control trial in 10 centers across the UK. And we enrolled adults who were presenting to the emergency department with palpitations or pre-syncope, so near blackout. And there was no obvious cause in the ED. And normally that meant that the underlying ECG in the ECG in the emergency department was normal and their symptoms had settled, so were unable to correlate their symptoms with an ECG. So we randomized patients to either the intervention group. They received standard care, plus they also received the AliveCore device, or a control group who received standard care alone. And our primary endpoint was detecting a symptomatic rhythm at 90 days. So just to give you an idea what standard care consisted of in our standard care arm, more than half of the patients who were in the standard care arm had a referral to some kind of medical practitioner, whether that was general practitioner, cardiology services, other outpatients such as medical services, or cardiac electrophysiology services. And the ones who were diagnosed during that time, you can see that the methods for diagnosis were Holter, and also as 12-lead ECG when they returned to their GP or the ED with symptoms. So as with all studies, we took a while to get going and getting the sites up and running, and we recruited our 243 patients over an 18-month period. You can see there's slightly more females than males, which is again common to this presenting complaint, and the majority of patients presented with palpitations. And you can see in the study we had patients up to the age of 74, so that didn't really limit the age obviously being a factor and using technology. So our primary outcome In the intervention study group, we found 55% of patients we were able to diagnose the underlying cause of palpitations by picking up an ECG at the time of symptoms, and this was 5 times more than in the control group. As would it be expected with palpitations, 16 to 17% of these were cardiac arrhythmias, so atrial fibrillation, flutter, SVT, and the rest were all non-cardiac rhythms such as sinus rhythm, sinus tachycardia, ectopic beats, sinus bradycardia. And that's common to most studies that investigate palpitations. We looked at how long it took to, on average, to detect the rhythm. And in the study group, it was about a week and a half. It was about 6 weeks in the standard care arm. We also looked at the pickup rate of cardiac arrhythmias, symptomatic cardiac arrhythmias. We picked up 11 in the study group, and we picked up 1 participant in the standard care group. So because they are randomized to each group, there's obviously still 10 patients who were in our control arm who were unable to detect their underlying cardiac arrhythmia during the trial. We looked at costs, and this included the cost of device, cost of coming back to access healthcare resources and to access investigations, and the costs were 3 times higher to pick up a diagnosis in the control group versus our trial group. This is just a snapshot of the patient reported outcome measures, and you can see patients were overwhelmingly satisfied with using the device. So back to our patient, Mrs. M, she was enrolled in the study. She had another further episode some weeks later whilst at home, and her live core ECG recording showed an AV node reentrant tachycardia. And her GP referred her up to the clinic, to the cardiology clinic, and she underwent a successful ablation. And she acknowledged it absolutely changed her life by allowing her to be able to go out and not be worried about getting symptoms where she was out. So I noticed the All Wales pathway for AF, the clinical pathway, does advocate use of an event recorder and devices such as the AliveCore for patients who may well have AF which hasn't been picked up. And we're now using the AliveCore device in our hospital, and we set up the smartphone palpitation service in Lothian. And the way this works is that patients who are seen in our emergency department or in our acute medicine units who present with palpitations but don't have an underlying cause in the ED or in our acute medicine unit, they come back the following day and they're seen in our acute medicine ambulatory service. Now, we looked at also in our study how long it took for us to detect underlying rhythms, and we found that more than 9 in 10 of the patients picked up a rhythm within the first 28 days. So what we've decided to do with our smartphone clinic is that we see the patients the next day, and we then see them 4 weeks later. And this enables us to turn over the devices a bit more usefully, and also allows us to be able to see patients shortly after they've recorded the rhythm, and they don't have to go for weeks on end then to be able to come back to be referred on. In our study, the patients emailed the ECG back to our study team. In the clinical service that we've set up, the patients come back, and the reason for that is that it means we're able to retrieve the device back off them, and also it allows us to be able to give them advice and to advise what the next steps if they do pick up a cardiac rhythm. And mostly it's referral to the cardiology service and sometimes back to their general practitioner, for example with AF, to think about anticoagulation and rate limiting medication. So the clinic's been up and running for more than a year now, and we looked at the first 3 months of the clinic to see how the clinic was performing. And during that time, we saw 68 patients being referred, of whom 54 were fitting with the device, and 50 of those came back after their period of monitoring. I should add, if patients did come back after 4 weeks and a diagnosis wasn't made, we did send them away again for a further 4 or 8 weeks with the device. Again, slightly more females than males, and we were seeing people up to the age of 80 in this clinic. About 8% of the rhythms we picked up were cardiac, and they were atrial flutter and fibrillation. But we do know over the following year, we've picked up many more episodes of SVT as well, flutter and fibrillation. So we looked at what lessons we could learn from the first few months to see how we could better improve the clinic. We sometimes felt that a 4-week follow-up was too long, and the clinicians within the acute medical unit did find that there were patients who recorded rhythm within a week and would phone the clinic and asking to come back to be able to get some advice and treatment. So we're keeping a default at 4 weeks, but we do allow the patient to contact the clinic if they do feel they've recorded symptomatic ECG. I'm keen we don't reduce that much longer than that, but we do know, as I say, that 9 in 10 patients were recording symptomatic rhythm within the first month. Our hospital Wi-Fi was particularly poor. We found that in the clinic, reception was very poor and it took a while to download the app. So we've changed that now so that patients download the app before they come back to the clinic, which saves a bit of time, and they seem to be very happy to do that. The patients were coming as well with expectations from the emergency department that they would be fitted with the device, and on occasions the clinic staff felt there was an obvious cause or that the patient didn't really warrant investigation. So we've made it clear that they'll be assessed for fitting with the device when they come to the clinic. The clinic's run by a wide variety of staff, and occasionally some of the more junior staff were not totally comfortable in interpreting the ECG, and because of that, if there wasn't a consultant around in the clinic at that time, we've made it then be able to have access to the emergency department consultants and the acute medicine consultants just to run any ECGs they want any clarity back on. But the clinic is consultant run a lot of the time, and there are lots of the decisions made obviously all at senior level, and we're trying to improve that as much as possible. The patients were sent away with diaries, but universally were very poorly completed, and we also found that during the trial. But we did find that patients would tend to only record ECGs that were made during symptoms, and we get them to sign a thing at the beginning just to say that they won't use it, they won't get other friends, relatives to use it down the pub and things. It's just for them, and they'll be the only people that will record rhythms on it. So the only other things to add was we slightly changed our referral criteria as well to make it clear that we should only be referring people to clinic in whom the treating clinician thought there was a high suspicion of a cardiac dysrhythmia. And if they felt it was likely anxiety, for example, or sinus tachycardia, sinus rhythm, then they probably weren't suitable for the clinic. And the evidence behind that was in the IPED study, we found that if the ED clinician felt the chances of the rhythm being a cardiac one was more than 5 out of 10, then they very rarely missed a cardiac dysrhythmia. So we felt that ED clinicians were able to make a reasonable assessment of those patients that didn't have a cardiac arrhythmia, and that these patients probably didn't warrant referral. They tend to be picked up at recording multiple episodes in the first couple of days, and these were probably best managed by maybe a bit more prolonged monitoring in ED, or probably a 24-hour tape which could easily pick up these rhythms within the first 24 hours. We decided we better log our devices a bit better so we could know exactly the devices coming and going out and who had what, and be able to not lose any devices. And we made sure that after 12 months we routinely changed the batteries to make sure we didn't lose any devices during when the patient had the device. So where do we go from here? So we're going to look at a year's worth of data to see if the changes we made after the first few months have improved the service. At present, only emergency department and acute medicine unit can refer to the clinic. We can't accept GP referrals at the moment. We're hoping to be able to be funded for doing that, and to integrate better with the cardiology service, which do use the device on a sporadic basis, but not as part of a clinic setting. And again, this is just really because we didn't want to be overwhelmed with patients being referred to the service until we got it established. We've collaborated with other health boards as well to help them establish services by sharing our protocols and guidelines. And this model is very generalizable to all different settings. It could be run within a GP practice, within a acute cardiology setting or clinic. It doesn't have to be within an ambulatory care setting, which is how we've done it. And obviously the service, given where we are at the moment with COVID, it does lend itself to be able to send devices out to patients. They can email ECGs back in and send devices back again, and consultation can easily be done over the phone. Cardia have also brought out a 6-lead ECG, which enables all limb leads to be recorded, which may allow better interpretation of ECGs. We're going to trial out on several patients in our clinic to see whether this does add to the pickup rate and the ease of interpreting the rhythms. But that was launched last year. So to summarise, we believe certainly in Lothian that a smartphone event recorder such as the IPED is safe, it's non-invasive, it's easy to use, and it really does offer something to patients who present with palpitations when previously we really didn't have anything to offer them. Thank you very much for listening. Any questions?